Welcome to AMiNDR, a podcast where we summarize the latest publications on Alzheimer's disease for you, so you can spend more time doing awesome research. For every month, you'll find a series of episodes by theme, and each comes with a bibliography. Whether you're in the lab, on the bus, or cooking your meal, we hope you find this podcast useful and accessible.
Hello everyone, welcome back for another episode of AMiNDR for papers published in August 2020. This is part 2 of modifiable risk factors. If you're interested in diet, vascular risk factors, obesity, diabetes, and exercise as potential risk factors or protective factors, I encourage you to check out part 1, which I also hosted. So, as a note, we're still calling this episode modifiable risk factors, but in the future we'll be switching over to just non-genetic risk factors, as there's some debate about how many of these are actually modifiable. Today I'll be going through, we have 7 papers on medical risk factors and comorbidities. Then we have 5 papers on hormonal and sex differences, and another 5 papers on sleep. So let's get started with the first section. This one includes papers on hearing and visual impairment as well as dental health. And the first paper we have in this section is one where the authors set out to investigate whether there's a relationship between retinal vein occlusion, or RVO, and the risk of dementia, as retinal vascular changes have previously been associated with brain changes in dementia. This was published in the American Journal of Ophthalmology. This was by first author Nam and last author Song. And the title of this paper is Retinal Vein Occlusion and the Risk of Dementia, a Nationwide Cohort Study. This retrospective cohort study looked at the association between RVO and subsequent risk of dementia within the Korean population. The authors used data from participants 40 years or older who underwent health examinations between 2009 and 2010, which was provided by South Korean National Health Insurance Service. They had over 46,000 participants who were diagnosed with RVO and had 3 comparison subjects per RVO patient, matched according to age, sex, and systolic blood pressure. The authors found that incident probabilities for all types of dementia were significantly increased in the RVO group relative to the comparison group. After adjusting for all confounding variables, the RVO group showed increased risks of subsequent all-cause dementia, Alzheimer's disease, and vascular dementia relative to the comparison group. Overall, this large-scale, population-based cohort study suggests that RVO is indeed significantly associated with increased risk of dementia. So next up, we have a mouse model of hearing loss and its effects on cognition. And I have to say this is the first time I've encountered a mouse model of hearing loss in the literature. This one is entitled Conductive Hearing Loss Aggravates Memory Decline in Alzheimer Model Mice. It was published in Frontiers in Neuroscience by first author Kim and last author Park. The authors investigated the effect of conductive hearing loss in the 5X-FAD mice. So this is a mouse model of AD. They used both PET and MRI to evaluate changes in glucose metabolism and gray matter concentrations in these transgenic mice, either with or without conductive hearing loss, which was induced by chronic perforation of the tympanic membrane. Hearing loss led to greater memory impairment in these transgenic mice, as tested in the Y maze and in passive avoidance tests. It also caused lower cerebral glucose metabolism in the frontal association cortex compared to the mice without hearing loss. There were also decreases in gray matter concentrations in multiple brain regions 7 months post-hearing loss induction. Thus, it seems that even partial hearing loss could aggravate memory impairment and lead to structural brain changes in Alzheimer's disease. I find this really interesting because I wonder if it's being cut off from your senses that causes memory impairment, or if it's really just something neuropathological. I'm really curious about how our senses and perception of the world shape our cognition. And this seems like an appropriate time to bring up that I'm aware that there's a pattering noise in the background. It's been raining in Montreal, and no matter where I record in the house, there's always some street noises. So hopefully you can consider it as calming rain sounds in the background of my voice. All right, this next study is not entirely related, so I'll keep it brief. It's on periodontitis, which is the severe infection of the gums, and how it affects oral health-related quality of life in individuals with AD. This was published in Clinical Oral Investigations by first author de Oliveira Araujo and last author Ferres Filho. And the title of this paper is Association Between Periodontitis and Alzheimer's Disease and Its Impact on the Self-Perceived Oral Health Status, a Case Control. And I encourage you to check out the bibliography if you want to see the first and last author and all the authors in between, because I recognize my pronunciation is subpar. This study tested the hypothesis that periodontitis is associated with AD and sought to determine if periodontal and other variables negatively impact people's perception of their oral health-related quality of life. The authors conducted oral examinations and interviews on self-perceived oral health status and collected sociodemographic data from outpatients with mild to moderate AD and from their age and sex-matched family caregivers. They found that periodontitis was the most associated with AD, but there were also other oral health factors that were worse in individuals with AD. However, periodontitis was not associated with the perceived health-related quality of life. So while we're on the topic of periodontitis and gum infections, I'm going to give a quick summary of a paper that explores the effect of P. gingivalis on microglia, which could underlie the association between periodontitis and AD. And I'm sure you've heard us mention P. gingivalis before if you've listened to any of the other episodes. All right, this paper was published in Neurochemistry International by first author Nonaka and last author Nakanishi. And this is actually a 2-author paper, so that's all of the authors. And the title of this paper is Secreted Gingipains from Porphyromonas gingivalis Induce Microglia Migration Through Endosomal Signaling by Protease-Activated Receptor 2. All right, so this group previously found that P. gingivalis, which is a major pathogen that causes periodontitis, induced migration and inflammatory responses in mouse microglia, specifically through gingipain-induced activation of protease-activated receptor 2, which is also referred to as PAR2. In this study, they further characterized the effects of secreted gingipains on cell migration in a human microglial cell line, which includes identifying cleavage sites of PAR2 by gingipains and subsequent signaling pathways. They found that including P. gingivalis in these cell cultures induced migration and membrane ruffling in the human microglial cell line through PAR2, and these phenotypes were inhibited by treatment with gingipain inhibitors. The authors performed further experiments, and the paper, or at least the abstract, describes mechanistic details. But as it's not directly related to our theme, I'll just keep it to this. So listen up. P. gingivalis causes the secretion of gingipains, which induce SRC and beta-arrestin-dependent internalization of PAR2, and further activate the ERK1-2 pathway to promote migration of microglia. So you can check out the paper for these details if you're interested in the mechanisms by which P. gingivalis infection could lead to sporadic AD. And if you're interested in mechanisms more generally, if you really like microglia or you want to hear more about signaling pathways, I encourage you to check out the disease mechanisms episodes. Moving on, this next study assesses the risk of impaired cognitive function in ICU survivors, considering factors such as age, severity of illness, days in coma, delirium, and mechanical ventilation. It was published in Acta Anesthesiologica Scandinavica. I think we need a wider range of language expertise in our hosting. I'm sorry I can't provide that here. Anyway, it was published by first author O'Colette and last author Perner. And the title of this paper is Risk Factors for Long-Term Cognitive Impairment in ICU Survivors, a multi-center prospective cohort study. The authors followed 237 adults that survived at least 6 months after acute admission to one of the 24 Danish ICUs participating in this cohort study. Trained professionals used the repeatable battery for the assessment of neuropsychological status, abbreviated to RBANS, to assess cognitive function in patients' home or in outpatient clinics 6 months after ICU admission. A total of 106 patients completed the cognitive assessment. Of these, 52% had a global cognitive score 1.5 standard deviations below the normative mean, and 36% displayed a global cognitive score 2 standard deviations below the normative mean, which is similar to what is observed in Alzheimer's disease. This suggests that cognitive impairment was frequent and severe in ICU survivors assessed at 6 months. Higher age was a risk factor for cognitive impairment in these patients, whereas events related to the ICU stay were not associated with poorer cognitive performance. Yet another random association with increased risk of AD and related dementias is bladder antimuscarinic drugs, which are also referred to as BAM drugs, particularly those with non-selective receptor binding. This next paper will tell you why. So this was published in Pharmacoepidemiology and Drug Safety by first author Barthold and last author Zissimopoulos. And the title of this paper is Alzheimer's Disease and Related Dementia Risk, comparing users of non-selective and M3 selective bladder antimuscarinic drugs. This retrospective cohort study compared ADRD, which is AD and related disorder risk, for users of non-selective versus M3 selective BAMs, and also examined ADRD risk associated with overall BAM use. The authors assessed Medicare claims for over 71,000 individuals who used BAM drugs during 2007 to 2009 and did not have an initial ADRD diagnosis. They compared the later incidence of ADRD between non-selective BAM users versus individuals using M3 selective BAMs, adjusting for age, sex, race/ethnicity, healthcare utilization, other medication use, socioeconomic status, and comorbidities. So they did a lot of adjusting. The authors found that non-selective and M3 selective BAM users had similar odds of ADRD incidence, and that overall BAM use was significantly associated with increased ADRD risk. Okay, here's a study that would also fit under disease mechanisms, but we've included it here as it sheds some light on how traumatic brain injury or other forms of axonal damage could cause AD pathology. It is called The Effect of Spinal Cord Injury on Beta Amyloid Plaque Pathology in TGCRND8 mouse model of Alzheimer's disease. It was published by first author Yuan, last author Lin, and obviously other authors, in Current Alzheimer's Research. The authors wanted to test whether axonal injury could contribute to the formation of amyloid beta plaques, focusing on spinal cord rather than brain injury. To do so, they performed spinal cord transection in transgenic CRND8 mice and in wild-type control mice, or littermates specifically, at 3 and 20 months of age. They used immunohistochemical and ELISA assays to determine the extent of axonal damage and changes in amyloid beta plaque formation or amyloid beta levels at both ages. The authors report widespread axonal pathology following spinal cord injury, as indicated by intra-axonal co-accumulation of APP and its product amyloid beta, specifically within the perilesional region of the spinal cord. While there was no amyloid beta plaque formation in the 3-month-old transgenic mice, the 20-month-old mice with established amyloidosis in the spinal cord showed a reduction rather than an increase in plaque burden at the lesion site following spinal cord transection. And this was relative to the tissue adjacent to the injured area as well as to the corresponding area in sham mice. Instead, CD68 positive macrophages and activated microglia were observed at the lesion site of the injured mice compared to sham animals. So overall, these results indicate that spinal cord injury within this AD mouse model does not cause the acute onset and progression of amyloid beta plaque formation in the spinal cord, and perhaps even induces a regression of plaque deposition. That wraps up our medical risk factors and comorbidities section. So let's move on to hormonal and other sex differences. So as I mentioned, we have 5 papers in this section. And first off, we have a huge collaboration, so huge it's cosmic, on whether childbirth or parity affects dementia, given that women are more at risk of developing AD. So the title of this paper is Does Parity Matter in Women's Risk of Dementia? A Cosmic Collaboration Cohort Study. That sounds nice. Cosmic Collaboration Cohort Study. So this was published in BMC Medicine by first author Bay, last author Kim. The cohort studies of memory in an international consortium, so that's Cosmic, and a whole bunch of other authors and collaborators. So this study collected and pooled baseline data from 11 population-based cohorts from 11 countries over 3 continents, totaling nearly 15,000 women aged 60 years or older. The authors used logistic regression models to investigate the association between parity and the dementia risk, adjusting for age, educational level, hypertension, diabetes mellitus, and cohort. Across all cohorts, they found that women having 5 or more childbirths, which is referred to as grand multiparity, had 47% greater risk of dementia than primiparis, which is 1 childbirth women, which had similar risk levels compared to women who had no childbirths or who had 2 to 4 childbirths. There were, however, additional regional and dementia subtype differences. When compared to women with 1 to 4 childbirths, grand multiparous women showed increased dementia risk in Europe and Latin America. On the other hand, nulliparous, so that's 0 childbirth, women had a higher dementia risk in Asia. There were some regional differences in the risk for vascular dementia, Alzheimer's, and other forms of dementia, which you can find within the abstract and the paper. Overall, this work demonstrates that parity is associated with women's risk of dementia, but not in a uniform or universal way. And as Sarah was going over my script for this, she brought up that perhaps it's a difference in stress. So obviously having multiple children might lead to a lot of stress for the women, but maybe also in certain places having no children could be associated with stress, either due to cultural pressures or maybe other lifestyle factors. It'd be really interesting to dig into what exactly is at play here. So this next abstract was super short and to the point, so I barely need to summarize it for you. It's even all in the title, which is 2nd to 4th digit ratio, so that's 2D to 4D, is associated with dementia in women. It was published in Early Human Development by first author Jiang and last author Pike. And basically, Alzheimer's is characterized by sex differences, as we've already talked about, and some of these may be due to differential sex hormone exposure during development. So here the authors show that finger length ratios, an indirect measure of prenatal androgen exposure, significantly differ in women with and without dementia. In the author's words, quote, "This finding links a relatively feminine in utero development with vulnerability to dementia in women," end quote. So next we have one on estrogen exposure more generally, which fluctuates across the female lifespan and may influence women's heightened risk of AD. This links nicely to findings of multiple childbirths, which increase sex hormone exposure. So this was published in Human Brain Mapping by first author DeLonge and last author Westley. And the title of this paper is Women's Brain Aging, Effects of Sex Hormone Exposure, Pregnancies, and Genetic Risk for Alzheimer's Disease. In this study, the authors investigated both endogenous and exogenous sex hormone exposure, genetic risk for AD, and neuroimaging-derived biomarkers of brain aging in nearly 17,000 middle to older aged women. They found that higher cumulative sex hormone exposure was associated with more evident brain aging, suggesting it may have adverse effects on brain health. This was as opposed to parity, indicating that the beneficial effects of pregnancies on the female brain are not solely attributable to modulations in sex hormone exposure. The authors also found women using hormonal replacement therapy had less evident brain aging when treatments were started earlier, but this was only in women with a genetic risk for AD. Next, we'll turn to male sex hormones. So actually, we already saw male sex hormones in the digit ratio paper, but let's look at it again in the context of a paper on the potential cognitive consequences of androgen deprivation therapy, or ADT, which is a common treatment among prostate cancer patients. This was published in the Journal of Urology by first author Sari Motla and last author Shariat. And the title of this paper is The Risk of New Onset Dementia and/or Alzheimer Disease Among Prostate Cancer Patients Treated with Androgen Deprivation Therapy, a Systematic Review and Meta-Analysis. The authors aim to address the need for a well-designed quantitative synthesis to summarize whether ADT poses a risk of dementia and/or AD. To do so, they conducted a systematic review and meta-analysis of the literature to determine the differential incidence of dementia and/or AD in prostate cancer patients who received ADT compared to those who did not. They searched the PubMed and Web of Science, They searched PubMed and Web of Science database from January 1st to 3rd, 2020, and performed 6 meta-analyses for all-cause dementia, AD, and all-cause dementia or AD according to the duration of ADT, so under 12 or over 12 months. After considering inclusion and exclusion criteria, 14 studies were selected. 9 of them reported all-cause dementia and 8 reported AD. 5 of these studies assessed these outcomes based on the duration of ADT, finding that the risk of new onset all-cause dementia and AD was higher in prostate cancer patients who received ADT compared to those who did not. This risk was more pronounced when androgen deprivation therapy was given for longer than 12 months. To follow that up, here's a cohort study on ADT and dementia risk in Taiwan. This was published in JAMA Network Open by first author Huang and last author Si. And the title of this paper is Type of Androgen Deprivation Therapy and Risk of Dementia Among Patients with Prostate Cancer in Taiwan. The authors used linked data from the Taiwan National Cancer Registry, the National Health Insurance Research Database, and the Taiwan National Death Registry, totaling nearly 23,700 patients with newly diagnosed prostate cancer between 2008 and 2015. Participants were grouped based on whether or not they received ADT, which includes gonadotropin-releasing hormone, that's GnRH, agonists, orchiectomy, or anti-androgen monotherapy. So those are 3 different types of ADT. The primary outcomes were all-cause dementia or AD, and the association with various ADT types was examined using the Cox proportional hazards model. From the original cohort, over 1,500 participants were diagnosed with incident dementia during a median follow-up of 3.46 years. And the study found that from the 3 ADT types that I listed earlier, the only one that was associated with an increased risk of dementia or AD was the anti-androgen monotherapy. So that rounds off our hormonal and sex differences section. So before we finish with the sleep section, let's take a quick break. Maybe even a mini nap.
Hey listeners, I'm here to let you know AMiNDR is recruiting. If you're interested in joining us, shoot us an email at amindrapodcast@gmail.com. You can also find us on Facebook, Twitter, and Instagram. Enjoy the rest of the episode.
Okay, welcome back. So before I launch into the next section, which is 5 papers, I just want to give you a reminder again that you can find all of the papers we list in our bibliography. So if any of these papers have piqued your interest, be sure to check it out. You can get it by signing up through the episode notes or through sending us an email. So the first paper in this section is on sleep, obviously, and how it relates to various aspects of AD physiopathology as measured by some biomarkers. This was published fittingly in Sleep by first author Targa and last author Pignol-Ripoll. And the title of this paper is Decrease in Sleep Depth is Associated with Higher Cerebrospinal Fluid Neurofilament Light Levels in Alzheimer's Disease Patients. In this study, 104 individuals with mild to moderate AD were submitted to 1 night of polysomnography. The following morning, cerebrospinal fluid was collected to measure biomarkers associated with amyloid deposition, tau pathology, neurodegeneration, axonal damage, synaptic integrity, neuroinflammation, and oxidative damage. The authors report that neurofilament light chain, which is NFL, and that's a biomarker reflecting axonal damage, is positively correlated with the time spent in non-REM1 stage of sleep, so that's the N1 stage of sleep, and this measure is negatively correlated with the time spent in N3 sleep. So basically, deep sleep was associated with lower levels of NFL, and light sleep was associated with higher levels. They also found that chitinase 3 like 1, okay, that's abbreviated to YKL40, and this is a secreted glycoprotein. So this was negatively correlated with sleep efficiency and the time spent in N2 sleep or in N3 sleep, whereas there was a positive correlation between N3 sleep and 2 different oxidative protein damage markers. So, overall, these correlations between sleep parameters and AD biomarkers suggest that disrupted sleep is associated with axonal damage and neuroinflammation. So, in particular, NFL may be a suitable biomarker for sleep disruption in mild to moderate AD patients, in addition to its role in predicting neurodegeneration and cognitive decline. And if you found this summary interesting, I recommend that you check out the biomarkers episode. We have one specifically on cerebrospinal fluid markers for diagnosing AD. Okay, this next paper looks at sleep and its relationship with major depressive disorder and AD. It was published in Neurology by first author Huang and last author Degan. And the title of this paper is Sleep, Major Depressive Disorder, and Alzheimer's Disease, a Mendelian Randomization Study. So this one, now that I'm looking at it, it could also fit in our genetics episode, our genetic risk factors. So if you're interested in genetic studies, check that out too. To examine the causal relationship between these 3 conditions, the authors conducted bidirectional 2-sample Mendelian randomization analyses. They obtained genetic associations from the largest genome-wide association studies, or GWAS, currently available in UK Biobank, the Psychiatric Genomics Consortium, and the International Genomics of Alzheimer's Project. Using this data, they estimated causal effects and performed sensitivity analyses to test for pleiotropic effects, and I suggest that you check the abstract for the nitty-gritty statistical details. After adjusting for multiple comparisons, they found that higher AD risk was significantly associated with the following factors: being a morning person, so that's definitely not me, shorter sleep duration, also not me, being less likely to report long sleep, earlier timing of the least active 5 hours, and a smaller number of sleep episodes. They also found that higher risk of AD was associated with lower risk of insomnia, but they did not find any evidence for a causal relationship between these sleep patterns and AD, nor between major depressive disorder and the risk of AD. So with that, the authors conclude that AD might cause abnormal sleep patterns, but not vice versa. Next, we have a paper on something I've always been curious about, namely whether disrupted sleep could lead to Alzheimer's disease by influencing the production or clearance of amyloid beta protein. This paper is entitled Effects of Long-Term Sleep Disruption on Cognitive Function and Brain Amyloid Beta Burden, a Case Control Study. It was published in Alzheimer's Research and Therapy. The first author is Thomas, and the last author is Claassen. In this case control study, the authors studied whether long-term work-induced sleep disruption was associated with cognitive function and brain amyloid beta burden. They followed 19 middle-aged male maritime pilots who had chronic work-related sleep disruption and were sex, age, and education matched to 16 control participants with normal sleep. After ruling out primary sleep disorders with in-lab polysomnography, additional sleep measurements were obtained at home using actigraphy, sleep-wake logs, and a single-lead EEG device. The authors assessed cognitive function with a neuropsychological test battery that is sensitive to early symptomatic AD, and brain amyloid beta burden was assessed in maritime pilots using PET-CT imaging. So compared to controls, the maritime pilots did report worse sleep, which was also confirmed by the actigraphy and EEG recordings. However, there were no differences in cognitive tests, and brain amyloid beta levels were all in the normal range. So based on this study, long-term intermittent sleep disruption had no effects on global brain amyloid beta levels or cognitive function, but it'd be interesting to repeat the study with a larger sample size. Here's a good follow-up, which is entitled Systemic Inflammation as a Moderator Between Sleep and Incident Dementia. It was published in the journal Sleep by first author Beryl and last author Himali. So the goal of this paper was to look at levels of the C-reactive protein, that's CRP, which is a marker of systemic inflammation, and determine if it was the connecting factor between sleep and incident dementia. Participants in the study completed a baseline serum CRP assessment followed by a polysomnography at home to measure multiple aspects of sleep quality. And based on the CRP levels, participants were placed in 3 groups, namely low, average, and high inflammation. The authors followed these participants for an average of 13 years, which is quite the commitment, to see if the CRP levels at baseline correlated with levels of dementia and Alzheimer's disease. So out of the nearly 300 participants, 43 developed dementia, and 33 of these cases were consistent with Alzheimer's disease. The authors report that in the high inflammation or CRP group, longer wake after sleep onset and more nighttime awakenings corresponded with a higher risk of incident dementia. In the lower CRP group, fewer nighttime awakenings were associated with a higher risk of dementia. So overall, this study concluded that inflammation does moderate the relationship between sleep, most notably nighttime wakefulness, and dementia risk. And it indicates that we have a lot to learn about how sleep health relates to neurodegeneration. All right, this last summary is short and sweet. It's also on the restriction of sleep, but this time in mice. It was published in Physiology and Behavior. The first author is Bryce, and the last author is Boom. And the title of this paper is Chronic Sleep Restriction Increases Soluble Hippocampal Amyloid Beta 42 and Impairs Cognitive Performance. As I'm sure you've guessed from that title, the authors examined the effects of chronic sleep restriction on hippocampal amyloid beta 1 to 42 expression and cognitive function in adult C57BL6 mice, so these are non-genetically modified mice, and they found that a 6-week chronic sleep restriction caused cognitive impairment, specifically in contextual fear conditioning, and increased hippocampal amyloid beta. And you can check out the abstract for a little bit more information, or hopefully also find the paper. So that brings us to the end of part 2 of modifiable-ish risk factors for papers, specifically peer-reviewed research articles published in August 2020. My cat wants to say bye as well, I guess. Stay tuned for part 3, in which I will cover cognition and educational factors, social support and other socioeconomic factors, as well as papers that looked at a variety of risk factors at once. So that'll be coming out soon. And in the meantime, I encourage you to maybe catch up on other episodes from papers in June, as well as the ones that will be coming out throughout this month. Okay, see you again soon.
That's it for this episode. A huge thank you to the team that is working on sorting, summarizing, and scripting these abstracts, as well as the operations behind AMiNDR. The music is from Journey of a Neurotransmitter by Anusha Kamesh, musician and fellow scientist, and now member of the AMiNDR team. You can find the original piece and her other music on SoundCloud under Anusha Kamesh or on her YouTube channel, AK Music. Interested in joining the team? Give us a shout! We can always use help with content development, podcast editing, advertising, and you can be part of a new and exciting venture. Reach us by email at aminderpodcast@gmail.com or follow us on Twitter. Oh, we're also on Facebook now. Don't forget to subscribe to our mailing list if you want access to the bibliography for each of our episodes. The references come with timestamps. Timestamps. So you can more easily locate the paper that caught your interest. Check our notes below for details on how to sign up. And very close to this, you'll also find a link to our feedback survey. Because, yeah, your feedback matters to us. So please, pretty please, let us know how we can make this podcast a better tool for you. And last but not least, thank you for tuning in with us. And on this note, we hope you found our podcast useful and accessible. Until next time.